Welcome back. Our final presenter for the day is Naomi Matsura from the University of Toronto. She's going to explain how combining ultrasound with bubbles filled with drugs can actually help cancer patients. Naomi?
Thank you very much. I really appreciate the opportunity to talk to you today. So what the main idea about our work and work that other people around the world is doing is to look at these clinical contrast agents, and these are agents that are already used in patients to see if we can improve the outcomes of these cancer patients. And the therapies that we're talking about are chemotherapies. This is a stock image of a patient undergoing chemotherapy. I'm choosing this figure because it's really illustrating the difficulty of these treatments on these patients. They're really challenging. The key aspects to recall about chemotherapies are there are many different types of treatments. Most of them are toxic to normal cells, so there's what we call dose-limiting side effects. That means how much we give the patient will be limited by how much the normal tissue can tolerate. The other thing that most people will know is that success is highly variable. So if you have two patients who are, for example, the similar age, similar stage of cancer, if you give them the same drug, they may respond very differently. So the current paradigm or thought about cancer treatment is that the treatment has to be tailored to that patient. So right now there's all sorts of different kinds of treatments and drugs that are being developed to treat different patients depending on how they're responding to the therapy. So in my area, or the people I work with, many of them work in medical imaging, treat patients, and they want to look at using what we call contrast agents that you inject into a patient to better characterize the tumors during the therapy, so you can adapt the therapy if it's not working. And the second thing you'd like to do is perhaps use ultrasound or medical imaging itself, or some form of it, to help deliver these drugs to a tumor in the patient. So the thing that the agent that we're looking at they're called microbubbles, and they really are just simply what we think they are. They're gas-filled colloids or spheres that are stabilized by some kind of biocompatible shell. They're typically submicron to about 10 microns in size, so they're around the size of a red blood cell, and they exhibit these short lifetimes. So you inject them into the body and you see where it goes. And after about a few minutes, you stop seeing them because they're being exhaled, the gas is being exhaled, the bubbles will fall apart and they will be removed from your system. So what's interesting about these bubbles is that if you insonate them with ultrasound, they will resonate, okay? So they will expand and contract in phase with the ultrasound, and they'll grow and shrink. And what is interesting about that is this growing and shrinking of these bubbles is size dependent. So it turns out the ultrasound that you're using when you go and get a diagnostic scan will result in resonance of bubbles around the size of red blood cells, like 1 to 10 microns. Okay? So we can use this very specific property of these bubbles to track these bubbles in a patient. And this is done, and this is a video from a colleague of mine, very old video, and I'm showing it so that you can, to show that it's an established technique. What you can do is you can use this oscillating bubble that's the size of a red blood cell as a surrogate for this red blood cell. So you inject this in the patient, and this is showing a liver of a patient, and you can see how these bubbles will perfuse or will fill the vessels as a function of time. What you'll see is there's a region here that's a mass that was pre-detected by the radiologist, and that area will fill differently. And that difference in filling will tell that radiologist whether or not this is a benign or metastatic tumor. So that's sort of how these bubbles are used. And what also happens is you can imagine these bubbles are resonating, so they're increasing and decreasing in size. You can actually increase the pressure, pump up the pressure of the ultrasound, and that can burst these bubbles. And that's what people are using for drug delivery. And this is, again, a very old idea. So you have these, so I'm just going to show it in these little figures. So you have an intact bubble, for example. You can pop this bubble using ultrasounds that focus outside the patient through soft tissue. So it's like a millimeter scale volume. And you can just locally pop them. And what that does is it increases the permeability of these blood vessels around that area. So if you co-inject drugs, they can preferentially diffuse, for example, into the surrounding tissue, shown here with these arrows. So these are called what we term often microbubble induced bioeffects. So that results in things like enhanced blood vessel permeability, sonoporation in allowing drugs to go into cells, or vascular damage at very high pressures. So let's see if okay. So one of the areas that I'd like to just talk about is this idea of this damage that we create in these vessels. So the whole tumor is made up of different sized vessels, and they're all really weird and not regularly formed due to the formation and the rapid proliferation of these cancers like this tumor. And what happens is that there's inside the tumor, you're going to have sort of like weaker vessels. So what you can do is you can inject microbubbles into this, similar to what we saw before, and you can actually pop these bubbles, cavitate them, and then you can collapse these vessels themselves. You can kill and collapse the vessels. And that's actually been shown to result in decrease in perfusion, so you don't see the bubbles perfusing in the tumor anymore. But what happens is after a day or two, you start getting the rim of the tumor starts to recover. Okay, so that's one of the issues. So I just wanted to emphasize that what people do with bubbles and drug delivery isn't something that's clinically used, and it's not that new in some ways. Okay, so we already have contrast echocardiography. So people use bubbles all the time for contrast echocardiography, for looking at whether a tumor is benign or malignant in various liver, kidney, and prostate cancers. And there's millions of injections a year. This is an old number for 2 million injections a year, and that was before the change in the reimbursement policy, for example, contrast-enhanced procedures in the US. So that number is probably much higher at this point. The other thing that people are using is trying to monitor different tumors for this idea concept of adaptive therapy as a function of time, and then this targeted drug delivery, for example, to the brain. So that's already in clinical trials. There's already patients being studied for this. And then there's other late in vivo, like preclinical animal work regarding radiosensitization and chemosensitization, as well as some early clinical trials. So I just wanted to emphasize that what we're talking about is already done. The difference that they're doing is they're co-injecting the drug and the bubbles separately. So they have 2 injections. So what that does is it doesn't decrease the systemic toxicity. So the idea that we're thinking, or myself and colleagues around the world, is if you can load the drugs directly in the bubbles, then you can actually reduce the toxicity to your normal tissue. So really, here's a little cartoon showing that. So you have your tumor deep within the body. You want to locally deliver the drug. And you also want to monitor the location of the drug after you inject it. And you want to trigger the release. So if you have these drug-loaded bubbles, assuming you can see these bubbles, you can image them like we did before. You can hit them with focused ultrasound from outside the patient, pop the bubbles, and you can image it again, and then you don't actually see the bubbles anymore. So you can have some sort of validation that something happened. So that's the concept that many of us are working on. The way we're doing this is we have hydrophobic drugs. The drugs that we're looking at are docetaxel, and we load them into the shell of these bubbles. And that's a technique that other people around the world have also employed. And really what we're trying to do is combine this concept of antivascular therapy, popping the bubbles in the middle of the tumor, and then using the chemotherapeutic outside to handle the rim so that they can improve the outcomes of the patient. So that would allow the co-injected bubbles doing the part of the vascular disruption therapy, and then also reducing the systemic toxicity that's been a problem in the past. Okay, so the problem with these bubbles, it's really hard to load lots of drugs on them because there's only that surface that you can attach these drugs to. So in order to improve that, we've decreased the size of these bubbles to nanobubbles, nano-sized bubbles. So that what that does is that we can inject the same gas volume, which is a limiting factor for patients, and load them and get more surface to volume area to load these drugs. Okay, so and then also there's opportunities like more cavitation nuclei, various things that allow us to potentially improve the treatment compared to standard microbubbles. Okay, so this is just an example of so we've only done mouse models. This is an example of what this looks like. So we have this B mode, which is what we would look at for just non-contrast imaging, so regular what you normally get if you go to the hospital and get a scan. And then on the right-hand side here, you'll see this contrast enhanced mode. See if these movies work. So what we see here is, if we do see it, is you'll see we can perfuse this with bubbles. Okay, so if you do something before the treatment, what you can do is you can see the bubbles are filling nicely. Okay, and then after the treatment, you would see that, if this works, is that in the case where you don't apply the therapy, you actually get the perfusion, you get the blood vessels are fine, but the ones that you apply this treatment to, there's no more vessels. The vessels have pretty much collapsed. Okay, so this is just an example of that, and I'll just conclude with my last slide. So this is work that's pretty recent, and this is work I'm doing with David Gertz's group at Sunnybrook Research Institute, and we are addressing these nanobubbles and these drugs that are loaded on these nanobubbles to assess drug delivery and vascular disruption therapy. So on the left-hand side here is our mouse model. The key thing I want to emphasize in this particular model is that it is not immune-compromised mouse. So it's an immune-competent mouse, and that means that it has a real immune system, okay? And we're leveraging that for this therapy. The other thing I want to emphasize is this is a very, very low concentration of drug that we're injecting and a low concentration of bubbles. So what we do is we inject these bubbles, we just do one treatment, and then we assess the treatment. So just showing two representative images. So these are 6 mice. These on the y-axis is the tumor volume. This is the days post-treatment. So we wait 8 days, and then after we inject the tumor grows, and then we monitor the size of the tumor as a function of time after the treatment. What's really interesting is without the drug, in the nanobubbles and high-pressure ultrasound, we actually see 2 out of the 6 mice, we see the regression of that tumor. So the tumor disappears, which is surprising to some people in this field, but has also been shown by using standard microbubbles using the same system. And this seems to be emphasized for a mouse that has a working immune system. And then if we add this drug-eluting nanobubbles, we actually see potentially an improved effect. So now we have 4 out of 6 mice, and this is again really low concentration, 2 orders of magnitude lower concentration of this drug than is used systemically in mouse models. So what we're hoping that this will turn out to be is this regression or treatment using a very low dose, so no problem to the patient, or our patient is the mouse at this point, and allowing this new idea of having this vascular disruption therapy and drug therapy together to reduce or change the impact of this tumor in the patient. So thank you. So this is just my acknowledgements. These are people who helped me on the expanded project, of which I'm only showing you a small section right now.
Thank you, Naomi.
Sorry.
Quick question that I had.
Yeah.
In the dual injection process, are you injecting directly in the tumor location, or is this okay? Then how do the bubbles know where to go, or are they just going everywhere?
They just go where red blood cells go. So what we consider this is a first pass agent. So what we do, or what clinicians do all the time with these bubbles, is they just inject them intravenously, and they circulate through the body, and you just track where they go in the body, similar to what you saw in that liver perfusion image. So they don't know to get in the tumor. Okay, so the focus, so we have to know where the tumor is. Okay, so that's where we use a focused ultrasound. So we already know there's a tumor. You focus the ultrasound there, and then you deliver the treatment as they pass through that region.
Gotcha.
Okay.
So it's not like, and how long does the ultrasound treatment, the focused ultrasound treatment last?
Okay, so it depends. So we did short bursts for, I think we did it for, 10-minute pulse lengths, 8-second repetition frequency for 8 minutes. So basically on and off for about 8 minutes. Colleagues have done for 5. So it depends on how long these...
Depends on how fast your heart's beating.
Yeah, how long you circulate for.
Right.
Okay, so what is interesting is we don't see any damage to, so you can focus it right on the tumor, so we don't see any actual damage or problems with these mice after the treatment, if you don't have the bubbles from the drug there.
Okay. We have questions from the floor.
Yeah, so does shrinking the size of the bubble to a nanobubble mean that you need a different ultrasound frequency?
Ooh, smart. Not for the treatment. Okay, so the treatment, this is pretty high pressure. For imaging, you would need a different frequency, and that would change the depth penetration of the ultrasound. So for this, we're not leveraging, we're not using the resonance aspect for the imaging as much.
Okay, thank you. And what other uses are there for this other than cancer? Could it somehow target antibiotic-resistant bacteria?
It depends. So all these questions will depend on the variant of the bubble, how much drug you need there, and how you're going to deliver it. So it's going to be determined by what we can give to that patient or give to our model, and how much drug you need and where it's going to go. Okay, so for example, we're doing inflammatory bowel disease, and the amount of drug you have to give or the treatment you are trying to give will be potentially a multi-infusion over a period of time, several times a week, and that's tolerable by that patient for inflammatory bowel disease. So in cancer, what we are looking at is trying to set this up so it works kind of similarly to the workflow that the patient is already going through. Okay, so those are the limitations. But yeah, so I don't know. And if you want to modify, one of the things, there's other things we're trying to do and other people are trying to do, which is target these to specific disease sites, which is adding a level of complexity and potentially issues to this kind of agent.
Thank you.
I was curious what limitation is the hardest wall, I guess? So you went from microbubbles to nanobubbles. Is the next step, I don't know which one it is. Is it like, can bubbles be smaller than nanobubbles so you could get a better surface area? Or would you try to find drugs that the chemical structure is either smaller or more potent for the size to fit on those nanobubbles? Which one's easier?
Okay, so those are great questions. So the issue is once they get too small, you can't see them anymore. So we don't get the image guidance. So we can actually see these bubbles, but only at very, very high concentrations. So once they start, so that's why we're saying we're running this treatment for 8 minutes, because we stop seeing the bubbles, but there might be some still there that we can't see. So that's how we are potential. So they will get smaller and smaller and get lower and lower concentrations as they circulate. And then you don't see them. So if they get even smaller than that, they may not be there. So and I just gave a talk this morning, there's a big question about validating these. And what are you actually looking at? What's actually working or not? And these are huge questions. So the other opportunity is people are saying, well, maybe you can do a longer infusion. So if you can't get enough drug, maybe you want to do similar to what people propose for other kinds of medications. Instead of doing a bolus, like an injection, you would do a very slow injection or repeat injection to get more drug. So all those things can impact, could create side effects, can also create opportunities for other things to happen in the patient that you might not want. So that's one of the issues that we have to consider. So in this case, we did what was really interesting in this very early data is we just did one injection and one hit of this focused ultrasound, and then we waited for 14 to 18 days. So most people do more drug, like 2 orders of magnitude more drug in the bubbles, and they do it a weekly treatment to see stabilization. So the fact that we didn't have to use very much drug, which is the key thing, we just want to reduce those side effects, and we had to do it once, means that there's maybe, it's still evolving, right? So maybe there might be some opportunities there that would reduce the toxicity to the patient, but increase efficacy.
Thank you. I think that's it.
Okay.
Great.
Thank you so much,
Oh,
Naomi.
no problem.
And that concludes our press conferences series for the day. I want to thank everybody, the presenters, those of you in the room, and those of you out there watching on the live stream. We really appreciate you stopping by and listening to some really great talks and uses of acoustical science. I'm Larry Frum. Stay safe, stay healthy, and we'll see you in Nashville in December.